what we wanted to talk about are some of the other aspects, the public health aspects of how we can affect change around hepatitis C, and that really means talking about the social determinants of health. And we know, for example, that there are inequities that we have created globally. Life expectancy in Sierra Leone before the recent Ebola outbreak was 34 years. And we look at Japan, for example, and it's almost 82 years. But that's not just between countries. We know there's a life expectancy gap of at least 20 years between the most and least advantaged Americans. And these inequities are things that we have designed. They're policies that harm human health, that create these inequities. And most of them have nothing to do with health care. Health care is a small portion of it, but it's the other socioeconomic, political, environmental conditions that we create that lead us to these massive inequities. So what we believe is that we need to use hepatitis C as a way to look at how can we affect disease elimination and a real population level health impact. And we need to do that by using a health equity lens. So we need to balance the prevention and the support for those who need it most with the care and treatment approach that is needed by all. If we look at prevention cheaper than a cure, this is just one example where a single hepatitis C treatment is probably equal to about 200,000 single non-reusable needles and syringes, whether that's for people who inject drugs or whether it's for injectable medications in other parts of the world. And so we need to think about balancing that. And we decided we needed to use this term Zeitgeist because we have both been reading a lot about inequities and social determinants of health. And Zeitgeist is a dominant school of thought that influences the culture of a period of time. And right now, the contemporary Zeitgeist around health is an economic approach. So it's all about favoring prioritization and personal responsibility, market fundamentalism, neoliberalism. So it's these words that talk all about how can we best look at finances rather than how do we best look at how we can support our populations to be healthy in the ways that we need them to be. So this results in countries that are competing to cut spending rather than investing in social determinants of health. That limits the ability of countries to protect the health and well-being of different parts of their population, particularly vulnerable parts of your population. And so we believe that in terms of social determinants of health, the right to health of marginalized individuals and populations is what we need to be addressing. And hepatitis C, more than being access to treatment for these people, but it's a way to try and encourage the social determinants and the supports that are needed for their vulnerable populations. So we have been focusing a lot on the top bit there, on people who inject drugs, on unsafe injection practices, but really we need to have a discussion about these questions. Am I good enough? Is that really, we heard from the previous speaker, we are limiting treatment because we have preconceived ideas around the economic benefits and the supports that people need. And this has impacts on a whole bunch of diseases, including hepatitis C. So the health equity advocacy dimensions that we think are important for this is, how do we translate this type of evidence that we have? The testers cohort that we have a lot of information that tells us about who is being infected and what the impacts of the population are. So who advocates for those health equity targets? Who creates those messages? How can we tailor them to a different political standpoints? And that's something that I've been working a lot on with Mel's help and others in BC. How can we help our politicians, decision makers, who to understand that it's not just about providing treatment. It's about the other things that we need to do to support our populations, to make a difference on a population level, not just on an individual treatment level. And what are the barriers enablers of this type of advocacy? And we've had a very tenuous political relationship with our federal government over the last 9 years where health has not been a priority. And so we're looking at now, how do we take these messages to our new government who have signaled to us that actually science and human health makes a difference. So our conclusions are to really eliminate hepatitis C and have an impact globally and in our country, we do need these well-designed programs, but we need to address prevention. We need to address screening, that whole continuum of engagement into care. We need to have the education and training, and we need to have the treatment standardization, absolutely. We need to have those things in place, but it's broader than that. We need widespread stakeholder involvement from civil society, policymakers, so that we can convert these issues and we can provide the supports that are needed to make a difference on a population level. And we don't want to undermine the work that we've done already, particularly in HIV. We can learn from those so that we don't undermine our prevention as prevention gains. And finally, we need to integrate hepatitis C, we believe, with other programs where we have these ways of thinking, these advocacy roles already in place, and clearly HIV is one of the ones that we need to try and harness so that we can have that infrastructure, we can have that advocacy in a way that is syndemic. And we need to apply health equity lens to challenge this zeitgeist around decriminalization and the facts that things like prohibition are causing more harm than good in terms of drug use, and the stigma and the social determinants of health for those populations that are truly affected by this. Thank you.